Welcome, everyone, to the Virtual Compassion and Action Conference. I'm Kathy Scopin, Member Experience Advisor here at the Schwartz Center for Compassionate Healthcare. On behalf of all of us at the Schwartz Center, we are so excited that you've joined us today. Please join me in welcoming Alyssa Larkin-Conlon. Alyssa is a speech language pathologist and research clinician at the Center for Aphasia Research and Treatment at Shirley Ryan Ability Lab. Alyssa, it is such an honor to have you with us today.
Thank you so much, Kathy, for that introduction. I attended the Compassion and Action Conference last year in 2019, and I was utterly inspired and refueled as a practitioner and advocate. So I am truly honored for this opportunity and to be with you all today. To share a little bit more about my background, as Kathy said, I'm a speech-language pathologist, and I've worked primarily in adult rehabilitation settings, and now in aphasia research at Shirley Ryan Ability Lab. Of course, as a speech-language pathologist, I've always been drawn to thought and work around improving communication through rehabilitation and evidence-based therapy. But in my practice over the years, I've also become passionate about a more holistic need within our healthcare system to make access to health information as equitable and as accessible for all patients as possible, particularly for those who have communication challenges. Communication challenges come in many forms across our settings due to diagnosis, maybe health literacy level, the primary language a patient may speak, hearing impairments, etc. The list goes on. And currently, personal protective equipment in the COVID context can also introduce communication challenges that many of us, I imagine, have become familiar with now. The topic of this presentation is communication accessibility. I'll speak to what that means and what it can look like in healthcare organizations. I will also share some examples of innovative educational programs in this area and guide you through reflections on the communication environment where you practice and perhaps opportunities for improvement therein. So you know, when I say supportive communication, I'm referring to when healthcare providers use communication strategies when we talk with patients to make information clearer for patients and make it easier for patients to share and give information in response. I'm a certified trainer in this area and have been working to find ways to get this kind of training to providers in my organization. And I'm of course thrilled anytime I have a chance to promote this kind of training more broadly as well. I recognize this topic may seem a bit abstract, so I'm hoping to make it as accessible and relevant for all of you in your work as possible. I also want this to be interactive, so we're going to use the chat function. We'll do some reflective writing exercises, so I encourage you to have pen and paper handy if you don't already. And I welcome questions throughout, and Kathy's going to help me manage those. So please go ahead and submit questions as they occur to you. On that note, I will ask that you use the chat function now to type in your clinical discipline and the kind of setting you work in. So for example, I would type in speech language pathologist, multi-level rehabilitation and research hospital. So go ahead and chat that now, please. And I'm hoping that'll just give us all kind of a sense of who else is in the virtual room with us. So I'm looking, I can't see the chat here. Okay, there we go. So I'm looking staff support, clinician, children's hospital, acute care research chaplain, medical social worker, bioethicist, clinical ethicist, researcher, palliative care NP, nursing administration RN. Wow, we've got quite a mix. I had a feeling this would be quality director, director of patient experience. Wow, we've got a really broad group of attendees. That is so exciting to me. Clinical health psychologist, mental health rehab counselor, adult outpatient, Clinical ethics, pediatric. Okay, so hopefully everyone else can see what's being chatted too. I encourage you to click on the chat so you can see and just have a sense of, again, who else is in the virtual room with us today. I will be asking us to interact a little bit as we go along. Thank you all for sharing your backgrounds. I really appreciate it. Oh, and one more, cancer survivor advocate, retired behavioral health clinician. Wonderful. Thank you, everyone. And again, welcome. Okay, I'm going to move us forward here. So these are my disclosures. I primarily want to highlight that the two projects I'm going to present to you about were made possible by generous support from the Coleman Foundation and the Kabiller Humanitarian Award. Okay. I'm going to start with a quick patient story that exemplifies what we'll talk about today. This is Vonda's story, and Vonda gave me permission to share her experience with all of you today. She's one of our research participants and community members. Vonda is a 34-year-old African-American transgender woman living in Chicago. Vonda survived a major stroke that resulted in a significant hemiparesis, or one-sided weakness, and relatively severe aphasia. Aphasia is a language disorder caused by damage to language areas and networks in the brain, typically by an injury such as a stroke or a traumatic brain injury. Importantly, aphasia affects someone's communication, but not their intelligence. To give you a sense of Vonda's communication, as a result of the aphasia, Vonda understands about 80% of what is said to her in conversation when people speak slowly. And she speaks in 2 to 4 word effortful sentences. She can read simple sentences and write 1 to 2 word phrases. Now, I'm a language therapist, so I'm trying not to overdo the clinical information, but I want to give you a sense of how challenging it might be for Vonda to have conversations that are important to her. I want to give you a moment to let that sink in. To imagine if you were in Vonda's shoes and your communication were limited in these ways, how that would feel in your day-to-day life, and also as you try to navigate a healthcare system for vital care. Imagine how Vonda would do in your organization or accessing the services you and your team provide. Prior to her stroke, Vonda had a very active social life and was a successful esthetician and ran a thriving beauty salon. Due to the severity of her language and physical impairments, Vonda could not return to her business and now supports herself solely with disability benefits. Vonda has had to adjust to these significant changes in her communication, mobility, and overall lifestyle. On top of all this, recently her father, with whom she had a complicated relationship, passed away unexpectedly. Vonda sought mental health support as she struggled to cope with all of this. She went to a wonderful, well-known nonprofit organization here in Chicago dedicated to serving our LGBTQ community members. Her primary care physician referred her and then actually personally introduced her to one of their excellent counselors to have her first counseling session. I saw Vonda the next day in our research center. Now, Vonda is one of the most stylish people I know, but when she came in that day, she was wearing sweatpants. I didn't even know she owned sweatpants. Typically, she'd come in laughing and smiling and dressed to the nines, but this day she was in her sweats and uncharacteristically quiet. When I asked her how she was doing, this proud, resilient, typically unflaggingly optimistic person burst into tears in front of me. As I supported her communication and conversation, she shared that she'd been really hopeful about starting the counseling process, but that when she'd met with the counselor, the person hadn't understood her communication disability, nor how to modify the conversation so Vonda could understand and get her thoughts and feelings across. She hung her head and indicated she didn't really get anything out of the session, and in fact, it had made her feel worse. She felt she would just have to do without counseling because of her aphasia, and that she would just have to find other ways to cope. But she was feeling pretty disappointed and overwhelmed by that prospect. Now, I want to be clear. I don't think this was the counselor's fault. And I'm sure that provider did everything in her power to support Vonda in that session. But because she didn't have the training on methods of how to modify her communication, the session was not accessible to her patient, Vonda. Ultimately, she was not able to provide Vonda with the care she desperately needed. And I'm quite confident the counselor also recognized the communication limitations and did not feel successful after the session. I wish I could say Vonda's experience is unique, but I've heard similar stories from many patients I've worked with over the years with a range of communication impairments, where communication barriers kept them from effectively and fully accessing the care they needed. Maybe some of you in the audience are thinking of similar stories patients have shared with you, or perhaps that you yourself have experienced directly with your patients. The good news is that this is a need that can be met successfully. My hope today is to share examples of how we can meet this need and help you consider whether similar efforts in your organization could yield similarly positive changes to the ones I'll share today. We'll come back to Vonda at the end of our session together. And now it's time for our first short break from me talking. This is going to be our first writing reflection exercise. I invite you to reflect and write down for yourselves your thoughts. The goal is to ground ourselves in the experience of a communication breakdown. So I want you to think about a time when you struggled to communicate with a patient. Where were you? What happened? How did the patient and/or family react? How did it impact the care that you were trying to provide? And how did you feel in that moment? I'm going to give you a couple of minutes and I'm going to set a timer here. Go ahead and start, and then I'll bring us back after that time is up. Okay, we're getting close to 2 minutes. So wherever you are, wrap up that thought, finish what you're writing, and we'll do some more reflection as we go. I'm hoping these exercises will provide some good food for thought and some takeaways you may be able to share with colleagues and build on going forward. As you listen, please keep in mind the patient populations or challenges you just identified. Think about how what I present applies or could be adapted to fit those patients and their needs. Okay. There we go. All right. Now that we're all hopefully feeling more connected to this topic directly, personally, these are my goals for the remainder of our time together. I'm going to give some context around this issue more broadly and present some concepts that are important to understand as we consider how communication happens in our settings. I'll share 2 examples of communication trainings tailored to 2 very different teams with very different patient needs, and offer you in the audience chances to continue to reflect and examine the needs and opportunities in your communication environments as we go along. I'm hoping by the end that'll stimulate some useful ideas and perhaps some discussion for us as a group. So context and the concepts of communication access and a communication environment. First of all, as healthcare providers and healthcare organizations, we've had a mandate from the Joint Commission since 2010 that states that effective communication is not only every patient's right, it is essential to quality care and patient safety. It is our responsibility as providers to address the communication needs of all of our patients while they are in our care. But what does that mean in practice, and why does that matter? So I want to think about this here. What does communication access mean? What does accessibility mean? I'm going to ask you all to use the chat function once again, and when you think of the term accessibility in healthcare, just chat what comes to mind as a provider. What do you think of when you hear the term accessibility? Able to receive services. Wonderful, yes. Invitation to participate, ramps, barriers removed, equal opportunity. Wow, these are broad, wonderful definitions of accessibility, easily available to all. I agree with every single one of these that's been said so far. Interacting with someone who is patient, absolutely. Providing services, which includes everyone. This is so neat, the range of perspectives that we have today. These are wonderful, kind of broad concepts that are coming to you when you think of accessibility in healthcare. No interruptions, able to receive services in a way that meets your needs as an individual, ease of use, absolutely. Okay, thank you everybody for jumping in. Interpreter services, including ASL, letterboards, listening, yes, yes, yes. Okay, I have got an experienced, knowledgeable group in the room, and that is really exciting. I will say, I think I agree with what everybody chatted and shared, and again, thank you for jumping right in with your thoughts. I will also say that I think that for many providers and in terms of the way that we operate in many of our healthcare organizations, there's more of a focus on accessibility in terms of our physical environment. And I start with that because even though this group is thinking more broadly already, which is wonderful, I want to use the idea of a physical environment and accessibility to a physical environment as kind of an analogy to help us understand the idea of a communication environment. So in terms of a physical environment, as a community of healthcare providers and as a nation really, we've worked to make physical environments more accessible for people with physical disabilities in accordance with the Americans with Disabilities Act. And I think we've made a lot of really positive, impactful changes over the last 30 years since its passage. However, we have not achieved the same level of accessibility in terms of communication environments for people with communication disabilities. Further, many providers receive direct training on how to accommodate patients who have physical disabilities or physical needs in our work. But most of us do not receive explicit training on how to accommodate our patients with communication disabilities as we're doing our work with them. So I'm going to share an analogy that comes from the Aphasia Institute of Toronto from Ora Kagan and her colleagues. They suggest we think about a situation in which a person who uses a wheelchair finds it difficult to get into the building where they work because it doesn't provide ramps or elevators. It's not physically accessible. In a situation like that, we say that the building should be modified. Those ramps or elevators should be put in. We focus on changing the physical environment for that person to make sure that it's accessible for them. and for anyone who needs those accommodations. We don't ask that person who's using a wheelchair to change or do anything differently. So we can think of our communication environments in similar ways, that we can change things about how we talk with our patients, right? Because the currency of a communication environment is communication, information, how we provide and get information from our patients. And the way that we modify that is by changing how that communication happens, changing how we talk with our patients, how we listen to them. And again, this very informed group has already thrown out some suggestions when you just think about accessibility in general that are applicable to a communication environment. And actually, the last person in the chat gave some specific examples. I'm going to ask you all to chat again. Examples you think of as communication ramps. That's how the Aphasia Institute encourages people to think about it. So just like we put a physical ramp in a physical environment, what are communication ramps? Things that you've seen either where you work or in another healthcare setting that makes information more accessible for people. So Deborah loved, chatted letter boards, listening, interpreter services. What other ramps can you all think of? Throw them in the chat. Pen and paper. Absolutely. Yep. I know I'm making everybody be active right at the beginning. Being agreeable to recording sessions for patient and family. Yes. Picture boards. Appreciative inquiry. Absolutely. Mini whiteboard. Yes. Infographics. Visuals. 100%. Slowing down the way you speak with the client. Large print. Nonverbal communication. Emotion cards. Video translation services. All right, I am starting to think that perhaps people who are here today, many of you have participated in a communication support training or communication strategy training of some kind, which is wonderful because you're right on the money. All of these examples are absolutely communication ramps. So you'll notice in what people listed, there's sort of a combination of actual tools, communication boards, for example, pen and paper, infographics, things that we can hold and share and show. And then there's the behavior of ourselves as healthcare providers, what we do with those tools and how we talk with patients. Someone said slowing down how we speak, maybe writing while we speak. There are all kinds of strategies that we can use in addition to these tools. And I'm going to get more into some specifics and examples a little bit later. I'm just going to read the last, allow the patient to speak and give them full attention. So important. Thank you, Nancy. All right, moving us forward here. So now we've thought about this term of communication environment and communication accessibility. How do we put in communication ramps to make our communication environments more accessible? Now I'm going to ask you to reflect again on your own environment and just give you a chance to write those things down again, 1 or 2 minutes, to make yourselves a list of some of the communication ramps that you see in effect being used in your environment where you practice, and to also list some of the communication challenges that you know patients and providers experience. You may notice that as you're thinking about ramps and challenges, you may also think of opportunities to amplify or increase the ramps or to address those challenges. Go ahead and write those down as well. And I'm going to time it, and then I'll come back. Okay, wherever you are, I'm going to encourage you to kind of wrap up whatever thought you are on, finish writing that sentence, and then kind of bring it back. We'll continue to have more opportunities to reflect as we go along and to build on what you've written and thought about so far. I'm going to take a moment quickly here too to just address, there was a question or an experience shared about when a participant experienced a husband speaking for or over his wife who had a communication challenge, and how frustrating that could be as a provider. I have definitely experienced this too, and I think that's such a great example of something that happens, and probably with the best of intentions from that husband. But it can be frustrating, and it can actually create a barrier, because when he's speaking for her, he may not know the direct clinical information perhaps we want to get from that patient, and he may not be privy to maybe some more complex things like her feelings or aspects of symptoms. We want to be able to talk to that patient directly, and sometimes it can be tricky to navigate how to honor that husband's efforts, but also create space for the patient to communicate herself, and then to be able to support her to do that. Um, and again, most of us don't receive explicit training on what to do about that, and how to model for the husband, and show that we can communicate directly with that patient with just the right supports and techniques. Thank you for sharing that. There was also an additional ramp of Google Translate, which is another interesting support, especially when working with our patients who speak a language other than English. Lots of good suggestions in the chat. Thanks everybody for all the interaction. Okay, in the interest of time, I'm going to move us forward and talk about now, why does this matter? Why is communication access important? Well, what does the evidence say? The evidence says that communication accessibility can be really impactful for our patients in really important ways. Research has shown that patients with communication disorders experience barriers that compromise their access to healthcare information. Think about that. So much of what we do involves providing important healthcare information, and a whole big sector or segment of our patient population doesn't have the same kind of access to that information. And that decreased communication access impacts really important things, such as patient safety, their ability to indicate their needs, and not surprisingly, their overall satisfaction with the care that we're providing for them. Interestingly, there was a study that came out at the end of 2018 that showed also how costly these kinds of communication breakdowns can be. This team looked retrospectively over the course of a year on a national level at the number of preventable adverse medical events that had happened for patients with communication with diagnoses of communication disorders, and found almost 700,000 events, which, had they been prevented, could have resulted in a cost savings of almost $7 billion. So very impactful on many different levels. It's also impactful for us as providers. The evidence shows that effective communication between patients and providers can promote personal connections, which can lead to improved patient perceptions and actual treatment outcomes. Furthermore, communication and genuine connection with our patients can lend meaning to our work as healthcare providers, and can also make the often challenging clinical work that we do more sustainable for us over time. So I hope I've convinced you that this is an important issue and a prevalent one. So now the question becomes, what can we do about it? The truth is that this is a complex and multifaceted challenge and need that exists across healthcare organizations and settings. And a complex problem like this requires a multifaceted, adaptive solution. One such approach that has been introduced and used in the literature is called communication partner training, or CPT. So just as we said, we modify our physical environments for patients with physical disabilities, we have to modify the communication environment for our patients with communication challenges. And we do this by training and empowering their communication partners, all of the staff and providers that patients are gonna talk with while they're in our care have to be empowered with knowledge and skills and tools to meet those patients' communication needs. I think of this as kind of a teach a person to fish sort of methodology, because communication needs, you can't address that. It's not a one-size-fits-all kind of problem. So the provider themselves has to be empowered to be able to meet a patient, understand the specific kind of communication needs they may have, and then use their knowledge of different strategies and tools to be able to adapt to that patient's needs as they're talking with them. So it's kind of a broad approach to this kind of complex problem. There's a lot of evidence to support the efficacy of communication partner training. It's been shown to be effective with patients with a wide range of communication challenges and diagnoses, including aphasia, traumatic brain injury, dementia. These strategies have also been used successfully with people who, again, have maybe a different level of health literacy, who speak a different primary language other than English. At the Aphasia Institute, they say these kinds of strategies and tools are for anyone who knows more than they can say. And so if you think about any of your patients you work with who know more than they can say, this kind of training is meant to empower providers to be able to adapt how they communicate with those patients so that it can be more efficient and more effective. The research also shows that these kinds of training, CPT, is most effective when we take a systems level approach, kind of working within the system of care, and when we tailor the training to the specific needs of the trainees on that team and the communication needs that they encounter with their patients. Kind of intuitive, but it bears out in the research as well. So what does this kind of training involve? I'm going to present just some brief, broad concepts to just kind of orient folks to this. I'm keeping it broad mainly because of time limits, but I do want you to have a sense of what this can entail before I talk about the programs that we implemented. So basically, you're teaching directly ways to structure provider communication. This usually involves direct teaching and modeling and practice, hands-on, often role plays, or maybe coaching during patient care, practice with feedback, because this can be kind of complex. You have to think on your feet, and so it takes a lot of practice to get comfortable and to be confident enough to adapt to each patient's needs. So again, what this training provides is it's designed to increase the knowledge of the trainee in terms of communication challenges and needs, to educate them on different strategies that they can utilize while they're talking and working with patients, and to provide them with specific tools that they can use depending on what they're communicating with patients about. Again, giving them plenty of opportunities to practice with those strategies and tools to get more comfortable. Here's just a little example. This is a yes, no, I don't know card, as we call it, and we put them in the back of our badges. This is becoming more and more common, I'm happy to say, at Shirley Ryan Ability Lab. And it's just to have an easy visual that someone can use to confirm a patient response. So, if a patient is not yes, no reliable, or they are having trouble on maybe answering a question in a clear way for us, sometimes they can point to something that's visual and written to be able to indicate that, and for us to feel more confident that we correctly understood whether they meant yes or no. So many of the yes, no questions we're asking are high stakes and pretty important. So this is just a simple example of a tool that we've been using with trainees that people have said has been pretty useful. Again, what this kind of training involves is helping people to make their communication practices adaptive and multimodal. So not just talking with their words to a patient, but also using other modalities, maybe writing while they're talking, writing keywords, using visuals. You guys have listed some of these things, pictures, infographics, things that don't rely so heavily on words. And then making sure those multimodal options and tools are available for the patient as well, so that they can use them as they're responding to our questions to get their information across, being able to gesture in a way that we can understand, for them to write if they need to, or use pictures, or perhaps a communication device. So that's an overview, and I'm going to mention and share resources at the end of this presentation if you want to educate yourself more and see some more examples of approaches and tools in this area. So now on to the examples I want to share from our organization, 2 different interventions that we implemented. And I'm going to go back here for a second. So let's see here. I want to show you these examples because I want to illustrate what tailored communication partner training can look like. The organization where I work, Shirley Ryan Ability Lab, is a multi-level rehabilitation hospital. We have inpatient care, outpatient, and day rehab, so different levels of care. We have very diverse staff in terms of the clinical disciplines, all the different services we provide, as well as the individual backgrounds each practitioner may have. We also serve a very diverse patient population in terms of both diagnoses and, again, their own personal and linguistic backgrounds. So there's a wide range of communication needs that we encounter as we provide care to our patients. These 2 examples I'm going to show you are to 2 different kinds of teams within our organization with very different communication needs. It's my hope to one day train everybody within our organization because I think it's relevant to all of our work. But I started with 2 really high needs, high impact groups, allied health clinicians, occupational therapists, physical therapists, speech pathologists, and nursing staff. So I want to present first about the allied health program. We called it Communication Champions, and it was a year-long interdisciplinary communication partner training. When you're introducing any kind of training or education, we have to consider first, who are the trainees? In this case, allied health, OT, PT, speech pathologists who have high interactions and communication opportunities with patients that are, again, high stakes in the rehabilitation process. So effective communication during therapeutic intervention and during patient and family education, for example, can really significantly impact rehabilitation outcomes. We also have to think about how we're going to provide this training to them to tailor it to their needs. We know for behavior change, the more we can adapt a training to the needs of the trainee, the more likely it is to stick and result in positive and sustained change. We also have to be realistic and think about feasibility in terms of how to get this training to our trainees, how to work within the structures within our organization to provide the training, to get it to the trainees, and also to make it hopefully sustainable over time. So for the Allied Health Group, we worked within our organization's internal professional development program. And again, developed this as a year-long training called Communication Champions. So the champion model was already in existence within our professional development program. It's basically a model of knowledge dissemination. You empower the champion, the trainee, and then they take the knowledge and skills back to their teams and model and share it with their colleagues and champion what they've learned in the program. Because this was accepted as an elective within the professional development program, it meant that I could draw applicants from all sites of care across our hospital system, and that the participation was incentivized or reimbursed for the trainees. And that goes a long way in terms of feasibility and sustainability for your participants. So I encourage you to also be thinking about, are there structures already within your organization that you could use to get training to your target population? Lastly, for me, it was important to find mentors within the organization. I became certified as a trainer in supported conversation techniques, but I was fortunate to also have mentorship from colleagues who were experienced in this area and also had been with the organization for a long time, so it could help me think through the best ways, again, to provide this training to the trainees. Okay, so what did the program design look like? There's a lot on this slide here, and I'm going to walk you through it from left to right. But the idea is, again, you're going to provide in this training knowledge and skill building opportunities to your trainees. Then moving on to the orange arrow, give plenty of practice in real life in their practice with patients during their work. And then lastly, encourage reflection as they go along and are building their knowledge and skills. So the way that we did this for the allied health clinicians, the communication champions, was over the course of the year, I provided 5 in-person trainings. And each training meeting included both a didactic portion where I was directly teaching concepts and modeling strategies, and then role plays and hands-on practice for the participants so they could apply what they had learned right away and get feedback from me directly. And then they would take those strategies back to their sites and be practicing using those strategies with their patients during clinical care. The curriculum was progressive, and importantly, each meeting kind of built on the previous one, and each meeting also included time for collaborative discussion and problem solving. Because it was an interdisciplinary, we've been working with interdisciplinary groups, that allows for problem solving from multiple perspectives, and we had some really rich opportunities to think through real challenges with our patients, and sometimes, cross-disciplinary suggestions ended up being the most effective, which was really exciting to see. Again, after the meetings, clinicians would go back to their sites, use these strategies with their patients, and that was the initial focus, to just get more comfortable with the concepts and strategies in their care provision. Then as they got more confident, as the program progressed, I supported them to teach and model the strategies for their colleagues. And they kind of launched themselves as communication champions by giving a case study presentation about one patient with a communication challenge they had worked with, illustrating the kinds of strategies and tools they'd used and how that it impacted the care and what outcomes they were able to achieve by more effective communication. Lastly, we had the participants do a survey of their communication environment, because again, my organization is diverse. There are different kinds of needs at different levels of care. And so this is an opportunity to examine and understand better at each site for each team, what are the facilitators for effective communication and what barriers are present. And if there are barriers, are there opportunities to implement resources or to improve things at that site of care for patients to make communication more accessible. We're into the 3rd round of this program as of this year. I ran the first meeting for this current cohort in July, and the program has grown every year. So the first group was a small pilot cohort of 4 clinicians, but I had all disciplines, OT, PT, speech, and actually all levels of our care represented. Then the program grew to 10 participants last year, and this year it's 14. And excitingly, it's also growing in terms of disciplines. We have a participant this year from our wheelchair seating and positioning department, as well as our orthotics department. So just more perspectives in the mix and more people who will be empowered to make communication more accessible on their teams for their patients. We also gathered feedback from the participants as we went along, and we did this in 2 different ways, both quantitatively and qualitatively, and I'm going to share some of that just a little bit of that data to give you a sense. Before I do, I'll just comment briefly also that the program has also grown now into a level 2. So we had communication champions level 1, now we have level 2 as of this year, because a couple of champions from last year, when they did their survey and identified barriers and opportunities at their sites, said, I want to do a project to address this. And so I'm supporting them to do that in this coming year, and we're going to collect some data and see hopefully what impact can be made with their projects, which is really exciting as well. So a little bit of preliminary quantitative data. So what we did is I've had the champions rate their own progress as they go throughout the process at each important training point. So they've rated themselves on their knowledge of communication strategies, their confidence, how often they're using these strategies, mentoring others. I'm just going to show you one kind of data point. This is one group and their progressive knowledge, their progressive ratings of their own knowledge of these communication strategies I was teaching them. It's a 7-point scale that goes from 1, no knowledge, to 7, very knowledgeable. And you'll see a range here that indicates the range of experience levels in that group as well. You see somebody all the way at the top, she's an experienced SLP. So she started out very knowledgeable, but she said she gained a lot in terms of learning more about how to teach and model for others, both colleagues and patients and families. You also see the person who rated themselves as a 3, that kind of maroon line, was an inpatient occupational therapist, starting out rating herself as kind of with minimal knowledge of these strategies, and over time getting herself from a 3 to a 6. So much more knowledgeable over the course of the training. And you see most people increase and then kind of maintain at those higher levels. So people really perceived benefit and improvement over time as they progressed through the training. Time is running a little bit short, but I'm going to share a very quick story from a physical therapist participant in the program that I thought was really meaningful. She is newer into her practice, about 3 years into her practice. She works primarily on the traumatic brain injury unit. And she went in to do an evaluation with a new patient. She was the first clinician of the day to evaluate, so not a lot of communication information in the chart yet from other disciplines. She knew this patient had a pretty significant processing difficulty, trouble understanding, and was minimally verbal, so not able to express a lot verbally. And she said she went in to the room and started her assessment as always, layering these communication strategies on top, affirming to the patient that she knew the patient knew what she was trying to say, writing things down for her, giving plenty of time for the patient to respond, helping the parent to step back so that she could directly communicate with this patient. And she said she was able to get through all of the tasks she needed to do in that hour effectively, and that she got a lot of concise information from the patient she felt confident was accurate. She said that she felt a lot less anxious than she would have previously going into that session before there were any, speech therapy notes. And she also said the patient seemed more at ease as the evaluation went on. And as she walked out of the room, the patient's mother actually followed her out and was near tears, saying, thanking this clinician and telling her that she hadn't seen, since her daughter's injury, she hadn't seen anyone communicate with her with so much compassion, or anyone who was able to make things so clear and really put her daughter at ease, and that she was just so moved by that and so thankful. I get a little emotional just thinking about it because I think it just speaks to the power of empowering a clinician and how much that can change and impact the care that we can provide and our patient and family experiences. Okay. Just briefly too, I ran a focus group at the end, and people really liked the design of both the theory and getting to put things in practice with lots of feedback, opportunities to reflect, and people did notice changes in their communication environment, especially among their teammates as they mentored and shared this information. They found people were more willing to ask questions, to write things down, to be multimodal, and that they and their teammates were starting to innovate and make their own tools for specific needs that came up on their teams. Now I'm going to present the nursing training program, which is a different design altogether for a number of different reasons. This was a 6-month multi-team communication partner training. The timing came from just that it was funded by an award that was time limited. So it was 6 months long, and there were also other ways that this structure differed from the allied health training. So this was provided to 3 floors serving patients with high communication needs, neurologically based diagnoses. And I am not a nurse, and so I had a lot to learn about the specific needs of our nursing staff, both our nurses and patient care technicians. And so I partnered with the nursing staff and nursing leadership to understand better really how to tailor this to them. And I actually started this training with focus groups to meet directly with the staff and find out from them, how do you think communication is going on your units? What do you find most challenging with patients? And I then went back and tailored the training I was going to give to fit their feedback. So I was able to provide the training to actually 92 staff members over that 6-month period. And again, similar conceptual design in terms of starting first with providing knowledge and skill building, direct practice. But this was done more in kind of like a blitz, like a one-time 45-minute training in person, because that's what nursing staff was able to support in terms of their time. So this was during their shift. So there were didactic pieces and then hands-on practice with feedback from me in 45-minute sessions. I provided 16 sessions total across all shifts. So some of them were at like midnight, for the night shift, or early morning, midday, to make this as available to as many staff as possible. After the in-person trainings were complete, I then went to each unit a number of times. And this was, again, a suggestion from the nursing leadership and nurse educators that said, this is going to be most meaningful if you get in there and do this with them during patient care. And so that's what I did. With the funding, I had supported time to go to these units at different time and just tag along with nurses, patient care technicians as they talked with patients. And I would do modeling, on floor coaching, and bring in resources, show them how to do it, have teach backs to try to help them really get more confident and get more practice with how to use these resources and strategies with their patients. I also developed resource binders, which included communication boards in multiple languages with picture representation of lots of things that the staff said they needed to be able to communicate with patients about on a daily basis. So immediate needs for care, as well as maybe symptoms, etc. And they said, we need those to be handy, within reach. And so we made these binders and put them at every single nurse's station so that someone could just step out of the room and grab whatever board they needed in whatever language they needed. After the on-site coaching, I did more follow-up focus groups and met with nursing leadership again to find out, first of all, from the trainees and the staff, how did this work for you? And then from leadership, what did you think? What are you hearing from your staff? And actually, there was very positive feedback in both. And I'll share just a couple of maybe stories from the nurses in the next slide of how this impacted care. Importantly, the nurse leadership was also really happy with the outcomes and the impact for their teams and for their patients. And so they worked with me to plan, we're now planning regular trainings for both new staff and refreshers so that this can be an ongoing, again, sustainable initiative to continue to maintain our accessibility in these communication environments for these patients. So I did pre and post surveys in those 45-minute sessions, and I asked different questions, asked them to list tools that they thought they would use with their patients. And I asked a couple of questions just straightforwardly about whether they thought they had learned more about their patients' communication needs, and 99% said yes. And if they felt more confident about how to address those needs. And again, 99% said yes. Interestingly, these 1% responses were from 2 different people. They were anonymous, but they were different surveys, so interesting. In general, people said that after the training, they were having better conversations and connections, less frustration, both for themselves and for their patients. Communication was faster and more efficient when they were trying to convey and receive clinical information. And they felt that because they were sort of less stressed and felt more prepared, it allowed them to have more empathy and be able to put themselves in their patient's shoes in the moment of communication challenge. One brief story that a nurse shared is happened with a patient who had aphasia. She was brand new to this inpatient unit and, new to the experience of having aphasia. She was an older woman, pretty modest, and the nurse and the patient care technician or patient care tech went in to help the patient take a shower, and they were trying to explain what they were doing and why, but the patient became alarmed and kind of upset as they were trying to help her into the bathroom and get ready for the shower, get undressed. It was clear that she was having trouble understanding and felt scared and upset, and she actually started to cry. And the nurse said, she told me this story, that she said to the patient, she just took a moment and stepped back and said, "Oh my gosh, I can tell you're upset. This must be really hard for you and maybe a little bit scary. I know you know what you're thinking, and it's hard to understand. This is what we want to do. We want to help you take a shower. We want to help you feel clean and feel good." Um, and so the patient kind of calmed down a little bit, and the nurse said, "Can I give you a hug?" And she did this gesture, and the patient nodded and then just leaned into her. And they had this hug, and it kind of reset the whole moment. They were able to help her have a shower comfortably. Her husband then came in and was delighted. And it's just a really powerful story, I think, of just how this really manifests in our care. I'm going to keep moving in terms of time. I'm actually going to give you 1 minute here for reflection. I know I presented a lot of information, but I want to give you an opportunity to just reflect on what you've heard in the designs of these programs and think about whether that fits some of the opportunities you identified to train communication partners in your settings. Are there elements that are applicable from these where you work? So go ahead and write those down for yourselves, and I'll time it here. Okay, and I'm gonna bring us back wherever you are. I want you to wrap up your thought, wrap up what you're writing. And time has flown in this session, so I am gonna kind of move us forward quickly to wrap up here. I had hoped we might have time for discussion and sharing ideas, but instead what I'm going to encourage you to do is take what you've written, maybe take a little time after this session and continue to reflect on any opportunities, pieces of those programs you think might be applicable where you are, and think about how you might be able to share them with your colleagues to maybe get the ball rolling to perhaps implement something similar where you are. As promised, here are a couple of resources that you can look into that have wonderful information if you want to educate yourself further on these kinds of communication partner training methodologies and tools. Aphasia Institute of Toronto and Aphasia Access. I'll also share just briefly that the end of Vonda's experience, what we ended up being able to do was actually go and partner with that organization and do a communication partner training for their counselors and actually other staff as well. And Vonda was a part of that training to help them understand her communication needs. She then was partnered with a counselor who had done the training, and she's been successfully having counseling sessions with that counselor since and has gained great benefit from that. So because of her courage and the organization's willingness to provide the time to do the training, they've really been able to make a difference not only for Vonda, but they've shared that it's benefited many of their other patients as well now that their staff are empowered to support communication in these ways. I'm ending with this lovely image, not just because it's COVID times and it's nice to think of these kinds of places, but also because I think of communication as a journey. And although we may wish it could be neat and linear like an aqueduct, it often isn't. But we can introduce structure that can really improve how effective and efficient our communication can be for our patients, and thereby how well we're able to serve them and make sure that our services are accessible to all of our patients. I will end there today. I thank you all for your time. It's been, again, such an honor to to present to you today. I'm grateful again to the Coleman Foundation and for the Kabiller Humanitarian Award to support these projects, and to my organization for supporting this ongoing and similar initiatives, as well as to my mentors in the Aphasia Center. I think we're almost out of time for questions live. So I put my email here. I would love it if you want to send me a question directly. I think we are at 3 o'clock my time. So I'm going to stop here. Thank you all again, and I'll hand it back to you, Kathy.
Thank you so much, Alyssa. What a fantastic session. We really appreciate your time today. And thank you to our audience for attending. Please keep an eye out for the recap of this week's sessions and an email containing a link to claim your continuing education credits for this session. We look forward to having you back on Tuesday for Enhancing Connections for Sustainable Wellbeing Among Physicians and Staff, a workshop led by Jessica Chen Fang, Barbara Cuden-Hernandez, and Kathy McMillan from Loma Linda University School of Medicine. We hope you have a wonderful weekend, and thanks again, everyone. Bye-bye.